The concentration of potassium in erythrocytes is a completely new biological marker that can be introduced into clinical medicine for the first time. Although methods for determining potassium in erythrocytes exist, they are not applicable in practice due to their complexity. We have developed a simple method for determining potassium in erythrocytes by ion-selective electrodes, on any available blood analyzer. The study of intracellular potassium homeostasis is thus possible, and our understanding of electrolyte balance reaches a new dimension. The introduction of the simple method for measuring potassium in red blood cells means new perspectives. For clinical medicine, this new marker has great diagnostic potential. It is now possible to examine the entire potassium balance, intracellular and extracellular completely. Accordingly, it became possible to determine the latent potassium deficiency and its targeted therapy. In intensive care medicine, potassium in red blood cells acts as a marker for oxidative stress and has high prognostic value. Medical science. This parameter is practically completely unknown. It also has great scientific potential. The simple method enables very innovative studies without expensive equipment. New research provides a wealth of information for publications, and consequently for a scientific career. The new method is an ultimate business case for the medical industry. Completely new technologies are coming, the possibility of measuring the total electrolyte status of the body. A whole new generation of blood analyzers is emerging. With the emergence of new areas to study this marker, the market for blood analyzers will expand. Our film is intended for a very wide audience. In addition to specialists in clinical medicine, it will be interesting for representatives of disciplines related to medicine. Experimental medicine, physiology, pathophysiology, biology, red blood cells researcher, veterinary and many others. The film will certainly be of interest to representatives of business and the medical industry. A separate section of the film will be devoted to the economic aspect. We wish our dear colleagues productive viewing. Movie content. We briefly describe the basics of erythrocyte physiology. Then we discuss the modern view of erythrocytes as an organ. Our method for measuring potassium in red blood cells using ion-selective electrodes is described in detail. We present results of our study in intensive care patients and the corresponding clinical cases. We propose our model for the clinical interpretation of these markers. Acting as a biomarker for oxidative stress in sepsis is demonstrated. We discuss scientific approach and finally economic options. Potassium in red blood cells. What is it? If we ask any doctor what is it potassium and what is it red blood cells, they will be amazed. But when we ask what is that, potassium in red blood cells, he'll be surprised. We will not find data on the clinical use of this marker in the literature. We conclude that the term potassium in red blood cells does not exist in clinical medicine. The reason for this is very simple. The practicable method of measurement is missing. Modern standard of measurement of electrolytes and erythrocytes. This is a flame photometry and atomic spectroscopy. Both methods require special equipment and trained personnel. Time per measurement 20 to 30 minutes. It is clear that these methods are unsuitable for a wide clinical application. Distribution of potassium in the body. 98% of the total potassium content of the body is located intracellularly. Only 2% of total potassium is available for measurement. This is potassium in plasma. The main part of potassium is not available for research, and intracellular potassium homeostasis remains completely unexplored. We have developed a method for measurement potassium in erythrocytes using ion-selective electrodes, which for the first time allows us to introduce this new parameter into clinical medicine. Measurement of potassium in erythrocytes is now possible on any available analyzer of electrolytes and acid-base balance. The measurement time is about 2 minutes. The method is easily mastered not only by laboratory assistants but also by other personnel. In intensive care units, this measurement is practically possible as point of care. Potassium in red blood cells, state of the art. What do we even know about this marker? Most studies are from the 70s, 90s, 20th century. At that time, erythrocytes served as a cell model for research on cell membranes, ion channels and the potassium-sodium pump. In clinical trials, low levels of potassium in red blood cells have been observed in some patient populations. Some data are contradictory. The causes of the low potassium concentration have not been discussed. In general, the data of that time are of little relevance today. With the introduction of ion-selective electrodes, flame photometry has been pushed out of laboratory monitoring, and there have been fewer and fewer studies on this parameter. Today it can be argued that the study of potassium in erythrocytes is no longer in the area of scientific interests. The content of potassium in red blood cells is an absolute scientific vacuum. The physiology of erythrocytes has been well studied at the most modern level of molecular biology. We will briefly discuss only those aspects that directly related to our topic, intracellular potassium homeostasis. These are the peculiarities of the cell structure, ion channels and the function of the potassium-sodium pump. The main feature of the cellular structure of erythrocytes compared to other cells in the body is that they are relatively poorly provided with mechanisms for survival. Absence of nucleus and organelles. As a result, erythrocytes are unable to protein synthesis and regeneration. Absence of mitochondria. As a result, energy supply is possible only through anaerobic glycolysis and the pentose phosphate cycle. Energy depletion occurs faster than in other cells, which leads to the so-called hypoxia of erythrocytes. In total, we can say that erythrocytes are the most vulnerable cells. And, accordingly, more than others are subject to the threat of destruction. As we will see later, this fact may explain some of the features intracellular potassium balance. Ion channels in erythrocytes. We consider the function of transport proteins. Active and passive channels transported. Ions channel selectivity. Let's take a closer look. Potassium-sodium pump function. Transport proteins. Transport proteins, or ion channels, located in the cell membrane, have the ability to change their configurations, and thereby change their affinity for certain ions, which is different on both sides of the membrane. This allows them to move ions across the membrane in both directions. Some channels are passive and do not require energy costs, for example, the diffusion of ions according to their ion gradient. Other channels are active, for example the potassium-sodium pump, which moves potassium and sodium ions against their ion gradient. This process is active and requires energy. Data on the concentration of potassium in other tissues are contradictory, and are associated with technical difficulties of measurements. Considering laws of ionic and osmotic equilibrium, we must firmly proceed from the fact that the concentration of potassium in all cells must be the same, about 140 millimoles per liter, which completely corresponds to the concentration of sodium in plasma. The erythrocyte is for us the only cell available for measuring potassium concentration. Most ion channels are selective, meaning they specialize in transporting certain ions. A minimum of 7 ion channels have been described. Of great interest to us are the first 3 channels. Potassium-sodium pump, magnesium dependent. Calcium-potassium transporter, Gardosh channel. Non-selective calcium channel. We only list the other. The labels show which ions are responsible for transporting them.
The sodium-potassium pump is an active transport mechanism. 3 sodium ions bind to the protein channel, and an ATP provides the energy to change the shape of the channel that in turn drives the ions through the channel. One phosphate group from the ATP remains bound with the channel. The sodium ions are released on the other side of the membrane outside of the cell, and the new shape of the channel has a high affinity for potassium ions, and 2 of these ions now bind to the channel. This binding again causes a change in the shape of the protein channel, and this conformational change releases the phosphate group on the cytoplasm side. This release allows the channel to revert to its original shape, and as a result, the potassium ions are released inside the cell. In its original shape, the channel has a high affinity for sodium ions, and when these ions bind again, they initiate another cycle. The important characteristic of this pump is that both sodium and potassium ions are moving from areas of low concentration to areas of high concentration. That is to say, each ion is moving against its concentration gradient. This type of movement can only be achieved by the constant expenditure of ATP energy.
Factors that inhibit the function of the potassium-sodium pump. The experiments prove the influence of various factors on the inhibition of the function potassium-sodium pump. In the clinical setting, these factors also occur in various combinations. These are any forms of hypoxia, acidosis, oxidative stress, as well as the effect of certain medications, for example, digitalis. The comparison with cork is not accidental here. Really, in experiments, it is possible to fix a decrease of the number active channels. Knowing the principle of operation of the potassium-sodium pump, it becomes clear that any inhibition of its function will be accompanied by a decrease in the concentration of potassium in erythrocytes with a simultaneous increase in the concentration of sodium. We will return to this phenomenon again and again. Factors that stimulate the function of the potassium-sodium pump. These include endogenous and exogenous catecholamines and corticosteroids, as well as certain medications, such as glucose, insulin, and magnesium. The result of stimulation is an increased intake of potassium into the cell, with a corresponding decrease in sodium levels. Recall 3 drugs that boost the flow of potassium from the plasma into the cell. These are glucose, insulin, and magnesium. This effect has been clinically proven, and these drugs have long been used in practice, with hyperkalemia, as well as in the combined use of potassium and magnesium in hypokalemia. Remember that the potassium-sodium pump is considered in principle to be magnesium dependent. Consider the main cations of erythrocytes. These are potassium, sodium, calcium, and magnesium. Cation concentrations. Data on the concentration of cations other than potassium are few and often differ from study to study. We bring average data. It should be emphasized that between the concentration of potassium and concentrations of other cations, a linear correlation is always observed, positive or negative. This interdependence is a key starting point for understanding intracellular electrolyte homeostasis. We calculated correlation data from aggregated data from various sources. Potassium. The concentration of potassium in erythrocytes, measured by the method magnetic nuclear resonance, is 140 millimoles per liter. Measured by flame photometry and our method, about 100 millimoles per liter. This difference is explained very simply. Centrifuged blood always contains the remainder of the plasma, and the density of erythrocytes in hematocrit is always lower than the density of cells in other tissues. Thus, we measure potassium in slightly diluted tissue. Sodium. The concentration in erythrocytes according to various sources is about 8-10 millimoles per liter. Sodium plays a special role in the intracellular electrolyte balance. It is always in a negative correlation with potassium. It is the ionic and osmotic antipode of potassium, and when potassium is lost, it always forcibly replaces it in an ion equivalent amount. It must be remembered that potassium and sodium are in constant osmotic opposition at the level of the cell membrane. Calcium. It is always in a negative correlation with potassium. Calcium has a great influence on the membrane potential. Magnesium. It is always in positive correlation with potassium. Plays an important role in the life of the cell. In this case, emphasize the fact that magnesium is absolutely essential for normal functions of the potassium-sodium pump. Anions in erythrocytes. These are amino acids, chlorine, phosphate, bicarbonate and hydrogen. There are very few data on the concentration of anions. The main part of the anions is represented by amino acids, approximately 230 millimoles per liter. The concentration of phosphate is 10-15 millimoles per liter. We did not find data on the concentration of chlorine, bicarbonate and hydrogen. In any case, the concentration of anions should correspond to cations. The main one is potassium. Part of the potassium in the cytoplasm is in a bound state. Erythrocytes as an independent organ. Research of the past 2 decades and the study of the so-called non-canonic functions of erythrocytes led to a radically new view of erythrocytes as an independent organ participating, in addition to gas exchange, in the general hemostasis of the body. Let us briefly consider the history of the study of erythrocytes over the past 50 years. Earlier erythrocytes were an accessible model for studying the function of the cell membrane. Until over the past 20 years, new technologies for studying the function of cells and organs have entered molecular biology. These are the so-called omics technologies. The use of modern methods has made it possible to study the so-called non-canonical functions of erythrocytes, that is, functions that go beyond the familiar function of gas exchange. Non-canonic functions of erythrocytes. Most of the non-canonical functions of erythrocytes have been described at a high level of molecular biology. We will list only a few of them. Increased plasma antioxidant levels. The erythrocyte membrane is well equipped with antioxidant protection. It has been shown that erythrocytes increase the level antioxidants and in plasma, thereby increasing its protective potential. Erythrocytes show in the capillary endothelium the effect of nitric oxide, capillary vasodilation. This effect is also associated with the cardioprotective effect of erythrocytes, improvement of myocardial perfusion. The listed functions of erythrocytes prove their participation in the entire body homeostasis. Sovereignty. Erythrocytes are independent liquid organs with their own homeostasis. Anatomically, erythrocytes are delineated from extracellular fluid with colloidomotic barrier. Functional space. All electrolyte shifts between erythrocytes and plasma occur initially only in plasma, that is, within one organ. Stand-in. Erythrocytes' metabolic status is dynamically equilibrated with other organs, and thus, represents their metabolic state. Diagnostic approach. Potassium measurement is the functional diagnosis of erythrocytes. The recognition of erythrocytes as an independent organ seems at first glance to be a purely theoretical reasoning. But, as we will see later, it is this point of view on erythrocytes that is the initial basis for understanding the mechanisms of intracellular potassium homeostasis. Thus, the measurement of potassium in erythrocytes should be considered a functional diagnosis of an erythrocyte as an organ. And in this aspect, this is absolutely equivalent to determining the function of the liver by its enzymes, and the function of the kidneys, by the content of creatinine. To conclude this section of the film, we want to remind our audience of one of the pioneers in the study of potassium homeostasis. This is an American pediatrician, Daniel Darrow, a brilliant clinician and scientist who has made a great contribution to the study of potassium balance back in the first half of the 20th century. Even before the advent of measuring methods intracellular electrolytes, he assumed that the cell membrane is semipermeable to potassium and sodium. He believed that the loss of intracellular potassium are replaced by an ion equivalent amount of sodium. He first described metabolic alkalosis associated with loss of potassium. He was the first to put into practice intravenous administration of potassium solutions and successfully applied it during intestinal epidemic in the USA in 1945. Eryptosis. An erythrocyte's suicidal type of cell death. That is a programmed form of cell death, before they reach their full lifespan. We will discuss the main causes of eryptosis, its triggers and algorithm, as well as its physiological significance. Erythrocytes are constantly transported through areas of stress. In the lungs, where the erythrocyte is exposed to oxidative stress. In the kidneys, where the erythrocyte is exposed to osmotic shock. In peripheral tissues, erythrocytes are exposed to free radicals, inflammatory mediators and toxins. Under these conditions, the erythrocyte membrane can be damaged. This inevitably leads to the release of hemoglobin in hemolysis, with the threat of complications, for example, kidney failure. Important physiological function of eryptosis. Eryptosis is triggered by various triggers. The process of eryptosis starts earlier, before the membrane may be destroyed. The protection against hemolysis is the physiological target of eryptosis. Triggers of eryptosis. More than 100 triggers are identified. There are oxidative stress, free radicals, hyperosmolarity, energy depletion, bacterial toxins, heavy metals, same antibiotics, inflammatory mediators, and many others. Any foreign substance in the body can become a trigger of eryptosis. The machinery of eryptosis is well understood, and it is independent of the nature and origin of the trigger. We present this process in a very simplified form, related to electrolyte dynamic only. The process of eryptosis can be roughly divided into 3 phases. Eryptosis, Phase 1. Oxidative stress and damage of membrane releases prostaglandins, which activate non-selective calcium channels, and lead influx of calcium into the cell and removal of the chlorine. At the micro level, enlarged calcium channels are clearly visible. Eryptosis, Phase 2. Calcium activates the enzyme scramblase, which leads to a change in the structure of the membrane, blebbing and cell shrinkage. Calcium activate also a selective calcium-potassium channel, this lead to efflux of potassium and chlorine. Eryptosis, Phase 3. It is accompanied by a massive release of potassium and chlorine into the plasma. Water follows osmotically. The erythrocyte finally loses its structure and shape, and is eliminated from the circulation. Moderate eryptosis within physiological limits contributes to improvement of red blood cells, and maintains a balance with erythropoiesis. Increased eryptosis in various pathological conditions exceeds erythropoiesis, and leads to anemia, which accompanies many acute and chronic diseases, sepsis, cancer and others. Phylogenesis of potassium homeostasis. This term, in all likelihood, does not exist in clinical literature of potassium homeostasis. We want to turn attention to potassium balance in terms of mammalian evolution. In doing so, we must assume that all physiological mechanisms have a single goal, the struggle for survival. We try to clarify the following questions. Causes of death of mammals in the wild. How important is potassium for survival? Which disturbances of potassium balance are likely in nature? Imagine the main causes of death of mammals in wild nature. Obviously, a very common direct cause of animal death is water deficiency and dehydration. Injuries with subsequent blood loss, illness and inability to obtain water and food. To increase survival under the action of these factors, evolution provides for physiological mechanisms of protection and compensation. First of all, this is an increased secretion of the hormone aldosterone, which leads to sodium and water retention. Is it possible for animals to experience intestinal potassium loss, similar to what we see in clinical practice? Losses such as ileus, vomiting and diarrhea are theoretically possible. The question is, will these losses be life-threatening? This question can be answered unequivocally, no. Animals are likely to die of dehydration, and before potassium losses reach dangerous levels. So, the protection from potassium loss has no biological utility. In mammals in the wild, all the causes leading to muscle damage with subsequent hyperkalemia are quite likely, that is, the same conditions, known to us from clinical practice. There are extreme muscular strain, when running or hunting, direct muscle injury, compression syndrome with forced immobilization. All of these causes can lead to muscle damage, followed by rhabdomyolysis, which necessarily leads to hyperkalemia and metabolic acidosis. We can draw a logical conclusion that the physiological mechanisms of protection or compensation for potassium losses are biologically inappropriate. Potassium is essential for life, but not for survival. Protection from potassium loss is biologically inexpedient, and it's not physiologically intended. Protection against hyperkalemia is biologically feasible. From an evolutionary point of view, the following physiological priorities of potassium homeostasis are logical. The main function of potassium homeostasis is maintaining normal plasma levels. Protection against hyperkalemia is as follows priority. Protection against hypokalemia is not provided by evolution. Dangerous losses of potassium are found only in humans. Because other primary hazards, such as loss of water and sodium, we can control. Empirical evidence. In our daily clinical practice, the described biological patterns of potassium homeostasis are constantly confirmed empirically. Normokalemia and protection against hyperkalemia, the main physiological priority. It is well known that in normal renal function, potassium can be overdosed only by the rate of administration. The kidneys immediately excrete excess potassium, maintaining normal plasma levels. Furthermore, it has been proven that with enteral administration of potassium, the excretion of potassium by the kidneys begins earlier than the level of potassium in the plasma rises. This is the so-called feed-forward reflex, which works like the well-known Pavlovian reflex. Lack of protection from potassium depletion and hypokalemia. The main causes of hypokalemia are intestinal losses and therapy with diuretics. Despite the large reserves of potassium in muscle tissue, hypokalemia is not compensated. New method, measurement of potassium in erythrocytes with ionoselective electrodes. We describe the principle of the invention, the necessary equipment and the detailed workflow. The preparation of the blood sample is derived from the flame photometry. This means that the blood sample is hemolyzed with aqua. The potassium is released, as ionized solution, and then can be measured with usual ion-selective electrodes. Workflow, general principle of blood sample preparation. The first step in blood sample preparation is hemolysis. The concentration of potassium in erythrocytes is very high. To reduce the concentration to the working range of the electrodes, a tenfold dilution is required. However, this dilution reduces the overall electrical conductivity of the solution. Therefore, a second step is necessary, the addition of a concentrated solution of sodium chloride. The solution is then ready for normal electrolyte measurement. We recommend setting up a set at the analyzer's workstation. The following equipment is necessary. Micropipette from 1000 to 5000 microliters. Micropipette from 100 to 1000 microliters. Small test tube 1.5 milliliters. Test tube 10 to 30 milliliters. 1 milliliter syringe, like insulin syringe. A standard heparin syringe. Bottle of 10% sodium chloride. Bottle with distilled water. Practice measurements. We describe in detail the step-by-step instructions for determining potassium in red blood cells on blood analyzers. We describe a special database to automate the expectations and accumulation of research results. We will present a disposable device for measuring potassium in red blood cells. Step 1. Routine measurement of electrolytes in whole blood. The sample volume should be about 1.5 milliliters. The rest of the blood is used to measure the potassium in the red blood cells. The following blood preparation steps are performed during a normal measurement. Thus, no additional time is required. Preparation of a blood sample consists of several steps. A. The rest of the blood is poured into a small test tube. B. 5,000 microliters of water are introduced into the beaker. C. 500 microliters of blood is drawn into the pipette. D. 500 microliters of blood is injected into the water. Immediately comes hemolysis. The solution becomes transparent. E. After 10 to 15 seconds, 500 microliters of 10% sodium chloride are injected into the hemolysate mix. The solution is ready to determine the concentration of potassium in at the usual measurement of electrolytes with 1 milliliter syringe. Now we describe a cheaper option of our method. Instead of micropipettes you can use usual syringes. With a certain amount of care, the results are quite acceptable. After the first measurement in whole blood, the syringe is emptied exactly to 0.5 milliliters. This step requires special precision. Errors in blood volume lead to errors in measurements, because the concentration of potassium in red blood cells is very high. With a 5 milliliter syringe, the water is placed in beakers. 0.5 milliliter blood is added to water. After hemolysis, 0.5 milliliters of 10% sodium chloride is added, with a 1 milliliter syringe. Mix the solution briefly with the syringe. The solution is ready for measurement. Step 4. Calculations. For the calculation of potassium in red blood cells, we need 3 values from 2 measurements. Potassium in blood. Potassium in prepared hemolysate. Hematocrit. Result of the calculation, potassium in erythrocytes we denote below as Chiari. Calculation, the formula. We present general formula, without intermediate calculations. The amount of potassium in plasma is calculated out. 12. This is the constant for the dilution of blood. With the other formula, a general intracellular deficit of potassium can be calculated. I.W. This is ideal weight. 90 is the lower normal range of potassium in red blood cells. The formula can easily be automated, for example in Excel. We will introduce later a database where all calculations run automatically and other patient data can be stored. Here is a specific example from a patient with intestinal atonia and metabolic alkalosis. Despite normokalemia, there is a low potassium concentration in red blood cells and a significant potassium deficit. We have designed a device that allows all operations involving the preparation of a blood sample in a closed container. Therefore, the user has no contact with reagents. So, any personnel can carry out the measurement. Device design. It consists of a closed cylindrical container, based on a standard 10 ml syringe. The container contains 5 ml of water. It has a built-in heparinized syringe for blood sampling. A thin plastic capsule containing half a milliliter of 10% sodium chloride is built into the inner wall of the container. Outside is a perforator to destroy this capsule. Working with the device, step by step. Step 1. Normal measurement of electrolytes. Blood volume about 1.5 milliliters. Step 2. Empty the heparin syringe to 0.5 milliliter. The heparin syringe contains a piston lock at a volume of half a milliliter. Step 3. The piston is pulled out, the water goes mixed with the blood, followed by hemolysis. Step 4. The capsule with sodium chloride is perforated, the solutions are mixed and ready for the measurement. Step 5. Potassium is then measured. In this section, we will present our first clinical observations of this parameter, the concentration of potassium in red blood cells. We examine typical patients in the intensive care unit, patients with clinical losses of potassium, postoperative complications, sepsis and organ failure. We will discuss the likely pathophysiological causes of a decrease in potassium in erythrocytes, and present the relevant clinical cases. Pathophysiological mechanisms of potassium decrease in red blood cells. We emphasize that we did not find discussions on this topic in the literature. Based on some experimental studies, general laws of electrolyte balance and our clinical observations, we suggest 3 main pathophysiological mechanisms leading to a decrease in potassium in red blood cells. 1. Direct pathological losses of potassium, intestinal or associated with diuretic therapy. 2. Inhibition of the function of the sodium-potassium pump, without direct loss of potassium. 3. Osmotic attack of sodium. Sodium osmotically displaces potassium from the cell, without direct loss of potassium. Pathophysiology 1. Loss and deficiency of potassium. 2 main causes lead to potassium loss and hypokalemia. These are intestinal losses and diuretic therapy. In both cases with a decrease in the level of potassium in plasma, red blood cells are probably the first cells from which potassium enters plasma to maintain its normal level. So, deficiency of cellular potassium is already observed in normokalemia. This process is likely to be exponential and to some extent moment potassium ceases to flow from the cell. Hypokalemia develops, which is a late sign of potassium deficiency. Pathophysiology 2. Depression of the potassium-sodium pump. With this dysfunction, potassium and sodium ions move according to their ionic gradient. Potassium diffuses from the cell into plasma, and sodium from plasma into the cell, in ion equivalent quantity. Pathophysiology 3. In this case, potassium is osmotically displaced from the cell by sodium and water. This phenomenon has been described in experimental renal failure. In this section, we present clinical cases that, in our opinion, confirm the previously listed pathophysiological mechanisms. 1. Loss of potassium during diuretic therapy or intestinal loss. 2. Inhibition of the potassium-sodium pump in respiratory acidosis. 3. Sodium attack in acute renal failure. Case 1. Potassium loss by diuretic therapy. A 55-year-old patient with a history of Wolff-Parkinson-White syndrome developed paroxysmal supraventricular tachycardia with a heart rate of 180 to 200 beats per minute. After 8 hours of unsuccessful antiarrhythmic therapy, the patient developed increasing cardiac insufficiency. Cardioversion was indicated. Potassium in plasma 3.8 millimoles per liter. Potassium in red blood cells 68 millimoles per liter. Potassium deficit, 1,200 millimoles. In preparation for analgesic sedation, an infusion with glucose, insulin, potassium and magnesium was initiated quickly. After 5 minutes, there was spontaneous cardioversion to sinus rhythm. Cardioversion was not necessary. Potassium substitution was continued up to normal concentration in red blood cells. This solution has proven its worth many times over in the treatment of arrhythmias associated with potassium deficiency. It contains drugs that have been proven to promote potassium into the cells. Spontaneous cardioversions often occurred before the start of the actual antiarrhythmic therapy. Case 2. Potassium loss and metabolic alkalosis DARO. Medical history. Marked intestinal atony, up to compartment syndrome, with a severe metabolic alkalosis developed in 70-year-old patient in the postoperative period, replacement of the abdominal aorta. Basic excess plus 22 millimoles per liter. Potassium in plasma 4,2 millimoles per liter. Potassium in red blood cells 65 millimoles per liter. Potassium deficit 1,360 millimoles. Therapy. Intensive potassium substitution with control of both parameters beyond normokalemia. The patient received 300 to 400 millimoles potassium per day. Significant clinical improvement with normalization of intestinal peristalsis was observed. Acute depression of the sodium-potassium pump. A 55-year-old overweight patient minus 140 kg, was ventilated non-invasively because of acute respiratory failure, with decompensated respiratory acidosis, PiCO2 130. Potassium in the plasma 5.6 millimoles per liter, potassium in red blood cells, 55 millimoles per liter. No special therapy. After the respiratory situation improved over 2 days, the PiCO2 was 60 and potassium in the RBCs was spontan in the normal range, 92 millimoles per liter. Case 4. Acute osmotic stress, sodium attack by acute renal failure. A 66-year-old patient developed acute anuria postoperatively, after several hours of vascular reconstruction with multiple angiographies. Clinically, the patient was asymptomatic. Potassium in plasma 4.2 millimoles per liter, potassium in red blood cells 62 millimoles per liter. No therapy was administered, hemodialysis was required. Based on our first clinical experience, we formulate the following conclusions and hypotheses. 1. The causes of low potassium in red blood cells are clarified based on the clinical history. 2. Hypokalemia is a late sign of potassium deficiency. 3. Only potassium in red blood cells correctly represents the potassium deficit. 4. Other causes of low potassium in red blood cells require treatment of underlying disease. Our first experiences include more than 200 measurements by intensive care patients. We are convinced that this parameter has a great scientific and clinical potential, and for the first time gives us the opportunity to evaluate extracellular and intracellular potassium homeostasis. To confirm or refute our hypotheses, we need controlled clinical and experimental studies. We now present the results of our first exploratory studies in intensive care patients. We present this material in the usual sequence. The aim of our study was to study the interaction of potassium in red blood cells with other plasma parameters, electrolytes and acid-base balance. Such studies have not yet been carried out. Patients: 370 randomly selected patients from intensive care units, regardless of gender, age, diagnosis and clinical condition. Setting: measurement of potassium in red blood cells on blood analyzer parallel to laboratory routine. Statistics: we discuss descriptive statistics. Correlations between potassium in red blood cells and other plasma parameters. New created derived parameters and regression model. Descriptive statistic: maximum value, 210 millimoles per liter. Minimum value, 68 millimoles per liter. Average, 125 millimoles per liter. Descriptive statistics allow the following conclusions. 1. A large spread of values shows the high dynamics of this parameter. 2. Elevated potassium content in red blood cells has not yet been described. Correlations of potassium in red blood cells with plasma parameters. We analyzed the correlation of potassium in erythrocytes with other plasma parameters of electrolyte and acid-base balance. No correlation was observed with any of these parameters. Also, the scatter point diagrams do not show any correlations between potassium in red blood cells and others plasma parameters. This trend shows the absolute independence between potassium in red blood cells and potassium in plasma. The course of potassium concentration in red blood cells has an S shape, typical of many physiological processes. New insights after correlation analysis. Based on these results, the following conclusions can be drawn. There is no direct relationship between potassium in erythrocytes and plasma potassium. Potassium in erythrocytes does not correlate with all plasma parameters of electrolyte and acid-base balance. Why no interactions with other parameters? Perhaps the interactions between potassium in red blood cells and other parameters are too complex, with mutual compensations, as in acid-base balance? Based on this logic, we generated two hypotheses. 1. Potassium in red blood cells has a discrete interaction with the chlorine anion in plasma. 2. This interaction has a buffering character, like acid-base homeostasis. Hypothesis testing. New derived parameters. In order to examine the discrete connections to chlorine in plasma, we calculated three derived parameters, all three related to chlorine in plasma. For better understanding, it is very important to present a mental equivalent of acid-base homeostasis for each new parameter. The first parameter corresponds to the standard bicarbonate. It is 24 millimoles per liter at pico 240 and pH 7.4. Value above or below standard value is well-known basic excess, positive or negative. Analogous to the standard bicarbonate is a value of potassium in red blood cells, which corresponds exactly to the chlorine concentration in plasma. The deviation from this value in both directions is what we call potassium in red blood cells excess. It can be positive or negative as well. The pH value is imitated as the third derived parameter, PRBC. Chlorine in plasma relates to potassium in red blood cells. This value is normally around 1, for the usual interpretation it is multiplied by 7. The cations and anions are also swapped for this reason. Short summary. Ka-Eri, potassium in red blood cells, think PiCO2. Ka-Eri excess, think basic excess. PRBC, think pH. And now the correlations between three derived parameters. Between potassium in red blood cells and potassium excess. Pearson correlation is 0.9. Between potassium in red blood cells and PRBC. Correlation is also minus 0.9. And now between potassium excess and PRBC. Here is a theoretical maximum linear correlation. The correlation reaches 0.98. All measurements are practically on one line. This is the buffer line of chlorine in plasma. Compared to the acid-base nomogram, the relationship between potassium in erythrocytes and chlorine in plasma is even easier to interpret, because of the clear linear relationships. Hypothesis testing, the results. Hypothesis 1. Potassium in RBCs dynamically bound to the chloride anion in plasma. It is confirmed. Hypothesis 2. This interaction has a buffer character, like acid-base balance. It is confirmed. Exploratory study, the results. What is editing? 1. Potassium in RBCs is an absolutely independent biological marker. 2. Potassium in red blood cells has close and buffer-like ratios to the chlorine concentration in the plasma. 3. Potassium in red blood cells has no relationship to its concentration in plasma. 4. Potassium in red blood cells has no direct correlations with other plasma parameters. The close relationship between potassium in red blood cells and chlorine in plasma, this is a new scientific discovery. These relations have almost a physical character. What is behind this robust law of nature? What causes are conceivable for the increased potassium in red blood cells? Which metabolic constellations are the causes for distribution of values on chart? Is there a connection with the specific clinical conditions? Is it possible to discover these regularities at all? The relationships between the electrolytes and acid-base status in intra- and extracellular spaces are extremely complex. And these relationships remain completely unexplored. Research on potassium in red blood cells is a scientific challenge and fascination at the same time. Discussion. The following topics will be discussed. What is behind the increased potassium in erythrocytes? We try to explain the possible causes of this phenomenon. We generate new hypotheses. And we present our model for the first clinical interpretation of potassium content in red blood cells. The increased potassium in red blood cells not yet described. However, there are also no known studies in critically ill patients. We observe this phenomenon only in patients with inflammatory conditions. Is this phenomenon related to the inflammation response? For the explanation of this phenomenon, let us remember the last phase of eryptosis. This phase is followed by a massive efflux of potassium and chlorine from red blood cells. The red blood cells shrink and are eliminated from circulation. The destroyed erythrocytes are eliminated from the circulatory system. But what happens to the released potassium? The released potassium definitely stays in plasma. Let's remember that the concentration of potassium in erythrocytes is 25 times higher than in plasma. It's easy to calculate. If the eryptosis causes anemia that results in a hematocrit drop of just 1%, that would raise the plasma potassium concentration to life-threatening levels, up to 9 millimoles per liter. And why doesn't hyperkalemia occur? We hypothesize that released potassium is taken up by healthy red blood cells, as protection against hyperkalemia. This would be a logical addition to the protective function of eryptosis, first against hemolysis, and now against hyperkalemia. What evidence do we have for this hypothesis? Evidence 1. The statistically significant negative correlation with hematocrit. In the group with increased potassium in red blood cell was the hematocrit significantly lower. And what about the released chlorine? We suspect that chlorine is also taken up by healthy erythrocytes, at the same time as potassium. That would be physiologically understandable. The red blood cells cleanse his organ of byproducts of eryptosis. It has been proven that chlorine ions cannot diffuse according to its concentration gradient, like cations. They always diffuse with cations, here with potassium. Evidence for this hypothesis. In the potassium-elevated group, the plasma chlorine concentration was significantly lower. All these processes take place in the plasma space, which is clearly separated from the extracellular fluid, with a colloidal osmotic barrier. Plasma is an intercellular space of red blood cells. Chlorine intake. What are the consequences? Intake of chlorine and other anions should inevitably lead to intracellular acidosis. And vice versa. Loss of potassium and anions inevitably leads to intracellular metabolic alkalosis. This constellation is well known to us in plasma: hypokalemia with alkalosis, and hyperkalemia with acidosis. A model for clinical interpretation. For the first assessment of diagnostic potential, the creation of preliminary diagnostic models is indispensable. We emphasize that this model was created on the basis of concrete measurement data, and not on the basis of theoretical calculations. As a basis for the model, we took the point scatter diagram between PRBC, that is pH of red blood cells, and potassium excess, the deviation from the standard value. All dependencies between derived parameters are shown particularly well on this diagram. This is practically the maximum achievable correlation, closer to 1. The vertical zero line of potassium excess divides the nomogram into two parts. On the left is the zone of metabolic acidosis, on the right, of metabolic alkalosis. The horizontal zero line of PRBC again divides the nomogram into two zones. Above the line is the zone of decompensated metabolic alkalosis. Below the line is the zone of decompensated metabolic acidosis. It is noticeable that the zone of metabolic acidosis is much larger than that of alkalosis. This corresponds to the fact that our physiology is designed to compensate for metabolic acidosis, which is also more common. The normal values for acid-base status of red blood cells. Ka-ARI, potassium concentration in red blood cells, 90 to 100 millimoles per liter. Potassium excess, plus minus 5 millimoles per liter. PRBC, 7, plus minus 0.5. Osmo ratio, ratio of sodium in plasma to potassium in red blood cells. This parameter will be explained later. Potassium in red blood cells und triggers. Based on our model, it is logical that the concentration of potassium in red blood cells is directly related to the amount of the trigger in plasma. The two main triggers for eryptosis are bacterial toxins and oxidative stress. Finally, we take three logical steps. 1. Potassium in red blood cells measures the amount of eryptosis triggers. 2. The set of triggers forms the intensity of oxidative stress. 3. Potassium in red blood cells measures the intensity of oxidative stress. The oxidative stress has now become measurable. Attention! This model is not universal. The model is appropriate for acute oxidative stress, for example, for inflammatory conditions. In the case of chronic development, other laws prevail. These are still to be researched. We now present our data from a prospective diagnostic study in patients with sepsis. Material is presented in the usual sequence. The following hypotheses were generated for this study. 1. Potassium in red blood cells changes with the clinical course of sepsis. 2. These changes correlate with the SOFA scale. 3. Potassium in red blood cells can be a measurable biomarker of oxidative stress. 4. Red blood cells is the first organ in multi-organ failure. Study design. Target. Testing of the above hypotheses. Subjects. 63 randomly selected patients with sepsis. Setting. Measurement of potassium and RBC on first, third, fifth day of stay. Descriptive statistics. The highest value, 240 millimoles per liter, the lowest, 61 millimoles per liter. Average, 126 millimoles per liter. Survived 42, 60%, died 21. 40%. In further discussions we will use only one parameter. This is potassium excess, the most sensitive of all. Potassium excess maximum value, minus 144 millimoles per liter. Minimum value, plus 60 millimoles per liter. Mean, minus 20. This area nomogram shows the mean values of potassium excess on the first, third and fifth days in surviving patients. It is noticeable that the mean values were always in the acidotic range. This is particularly demonstrative if you project the values onto our nomogram. Now the same trend of potassium excess in deceased patients. Here we see a completely different development. After the third day we notice a sudden shift in the area of intracellular metabolic alkalosis. Correlation with SOFA scale in survivors. The connection is very clear. With the improvement of the clinical condition, SOFA falling, the degree of metabolic acidosis also decreases. Correlation with SOFA scale in deceased patients. As the condition worsens, a shift towards metabolic alkalosis is noticeable. However, it is striking that the tendency to alkalosis occurs earlier than the reaction from SOFA scale. Basic excess of plasma, potassium excess and SOFA scale are shown on this line nomogram. This is probably the normal development. Plasma acidosis and red blood cell acidosis are maximal on the first day. With clinical improvement, both parameters normalize. This trend is thus linked to the good prognosis. The same nomogram in deceased patients. The combination of plasma acidosis and intracellular alkalosis is associated with poor prognosis. It appears that a rapid transition to intracellular alkalosis is particularly dangerous. Here the two trends are shown together again. It is evident that the tendency to intracellular acidosis is associated with a good prognosis. This is understandable, as far as our physiology is well equipped to compensate for acidosis. And vice versa, the metabolic alkalosis is associated with a poor prognosis because our body is not well prepared to compensate for the alkalosis. We present a plausible explanation for the dynamics of all parameters in case of positive prognosis. Oxidative stress triggers eryptosis. This leads to the absorption of released potassium, and increase of potassium in red blood cells. If the course of the disease is positive, oxidative stress and eryptosis decrease, the red blood cells release potassium again and the potassium in RBCs normalizes. The plausible explanation for a poor prognosis. With the negative development and pathophysiological escalation, a massive eryptosis develops, but the still healthy red blood cells suffer from the stress, loss of energy and depression of the potassium-sodium pump. The absorption of potassium is therefore restricted or not possible. The red blood cells lose potassium, metabolic alkalosis develops, sodium invades. This stage denotes a red blood cells failure. The transition from acidosis to alkalosis may indicate red blood cell decompensation and failure. We demonstrate a clinical case of deceased patients where these processes are completed in the shortest possible time. The patient with an extensive facial phlegmon. First measurement on the first day shows a normal reaction to oxidative stress. 2. Oxidative stress has increased, with a corresponding rise in potassium concentration. Everything still in the area of metabolic acidosis. After the second measurement, the condition of the patients drastically worsened. The phlegmon expanded, further surgery was required. 3. This is the time of decompensation of red blood cells. A rapid drop in potassium in RBC follows, accompanied by severe metabolic alkalosis. The patient died a little later in fulminant multi-organ failure. On this graph we show the prognosis related to the acid-base status of red blood cells. This is the last measurements in both groups on the 5th day of stay. Group 1. Metabolic acidosis, potassium excess less 0. Deceased 15%, survivors 85%. Group 2. Metabolic alkalosis. Potassium excess higher than 0. Deceased 73%, surviving 27%. Intracellular metabolic alkalosis is life-threatening. Here is the course of potassium in red blood cells along with potassium excess in the survivor. A parallel course trend in the area of mild metabolic acidosis. A converging trend can be observed in deceased patients. The falling concentration of potassium in red blood cells is associated with the tendency to metabolic alkalosis. The same tendency with a fulminant course, Patient with severe sepsis, demonstrated above. Let's sum up the results of the study, and testing of the hypotheses. 1. Changes in potassium concentration and RBC are associated with the course of sepsis. Approved. 2. Potassium and RBC correlates with SOFA scale. Approved. 3. Potassium and RBC can be a marker of oxidative stress. Approved. 4. Red blood cells are the first organ in multi-organ failure. Approved. What name do we give the new biomarker? The original parameter, potassium excess, is inconvenient for interpretation. Especially, since it is mostly in the negative range. We suggest the name, RBC stress factor. And reverse the values. Values are in the positive range. Denotes a normal response to oxidative stress and reflects the intensity of the stress. It also sounds logical, because positive values are also associated with a good prognosis. Negative values means poor response to stress, dysfunction of red blood cells, risk of RBC insufficiency. As preliminary standard values, plus, minus 5. So, in the group of survivors the average was, plus 8.3 millimoles per liter, in the group of deceased, minus 5.2 millimoles per liter. Potassium and RBC as biomarker. Definition and criteria for biomarker. Does the potassium in RBC meet these criteria? Does it have clinical relevance? Definition of biomarker. The biomarker is any substance, structure, or process that can be measured in the body or its products and influence or predict the incidence of outcome or disease. Modern markers of oxidative stress can be measured, but they are not clinically relevant. Most biomarkers for oxidative stress are sophisticated and technically very complex. They are unsuitable for clinical use. Oxidative stress and sepsis, state of the art. Definition of oxidative stress, a disturbance in the pro-oxidant-antioxidant balance in favor of the former. It is evident that sepsis is characterized by excessive production of oxidants. The oxidants represent the generator of the abnormalities that lead to increased mortality. Although the diagnosis of several biomarkers is possible, this has so far been reserved for science and has not been established in clinical routine. Oxidative stress and red blood cells. It has been proven that erythrocytes are uniquely vulnerable to oxidative stress. RBCs are one of the first cells to be affected by changes in the redox status of the body. Red blood cells are best suited for the early diagnosis of oxidative stress. Criteria for clinically relevant biomarker. A clinically useful biomarker must be able to meet one of the following criteria. 1. Show specificity for a certain disease, diagnostic. 2. Have prognostic value. 3. Correlate with disease activity. This then allows treatment efficacy to be assessed. To be clinically useful, a biomarker must also be reasonably stable, present in an easily accessible tissue, and cost-effective to measure reproducibly on a large scale. RBC stress factor fully meets all of these criteria. Three main approaches for this biomarker in critical care medicine. 1. RBC potassium low. Indicates a potassium deficiency or red blood cell insufficiency. 2. RBC potassium high. Means an acute oxidative stress. 3. Monitoring during antioxidant therapy. The following quote attributed to Hans Selye might well apply to the concept of oxidative stress. If only stress could be seen, isolated and measured, I am sure, we could enormously lengthen the average human lifespan. Maybe RBC stress factor can become one of them. Why do you need a database? Reason 1. Mainly to automate the many calculations. 2. Storage of data for prospective or retrospective studies. 3. Collection of clinical experience with this parameter. 4. Easy for routine diagnostics. Diagnostic algorithm according to our model is integrated into the database. The main menu is self-explanatory. When opening the database, the main form appears. The left window contains the personal details of patients. A new data record is created with the New Patient button. First, we recommend entering the patient number, for example case number. The patient's ID appears in the database. Fields A and B are for encoding of patient groups, for the studies. After entering the date of birth, the age is automatically inserted. The length of stay is also calculated after the patient has been discharged. The measurement form. It is recommended to start each form by entering the date. A new data record for the measurement will be created. The yellow fields are mandatory fields for the following calculations. Switch with Tab or Enter key. After entering hemoglobin, all calculations are performed. The report can be viewed and printed. Button New Measurement creates a new record for this patient. Several clinically relevant data can be recorded parallel to the measurement. Of course, they have to be there in a timely manner. All forms are very similar. Each new record should start with entering the date. Any number of records are possible in each form for the same patient, the principle of a relational database. Scientific perspectives. Potassium in red blood cells is a completely unexplored biomarker that holds great scientific potential. Innovative research and new discoveries are possible without the use of expensive high-tech equipment. Opportunities are opening up for massive accumulation of valuable material for a scientific career. This marker is completely unknown, which means that each measurement is unique. Therefore, the first studies have a relatively simple design. First storage of data, then prospective or retrospective analysis, and material for publication is almost ready. As the main intracellular cation, potassium in red blood cells is of interest to all areas of clinical medicine. We name just a few of them here. Intensive care. As a biomarker of oxidative stress, and control in treatment of severe metabolic alkalosis. Cardiology. Detection of unrecognized intracellular potassium deficit, with potential cardiac arrhythmias. Nephrology. Research into unknown potassium imbalances in renal insufficiency and dialysis. This parameter may be of great scientific interest for others, disciplines related to medicine. Experimental medicine. Physiology, pathophysiology, biology, and molecular biology. This can also be of interest for veterinary medicine. For the introduction of this marker into clinical routine, the automation of the method by medical industry is absolutely essential. That would not pose a problem for the medical industry, provided a business case is identified. The only way to get there is extensive studies with the acquisition of clinically relevant data. Only then can the medical industry recognize a business case. The automation of the method does not require fundamentally new technologies. Only extensive coordinated studies bring the scientific breakthrough. The arousal of interest to this parameter is the main intention of this film. We are happy to help with technical questions and study design. The studies cited here are conducted in 2 countries, with the fulfillment of all ethical requirements. The introduction of these biomarkers into practice means a revolutionary development and an ultimate business case. The emergence of new areas of clinical interest will lead to expanding markets. With NOI technologies, the complete intracellular electrolyte status is measurable. Three cornerstones for business case. 1. The development of new technologies for the measurement of potassium in red blood cells means new patents and new products. 2. Interest in this parameter in new clinical areas, especially in the pre-hospital area, leads to the expansion of the market for blood analyzers. 3. The completely new generation of blood analyzers is created, for measuring the entire intracellular electrolyte status. Our experiments have shown that, in principle, it is also possible to measure calcium and magnesium in red blood cells. Thus it is possible to completely measure the intracellular electrolyte status. The preparation of the blood sample is also based on hemolysis and release of intracellular electrolytes. Step 1. The conventional measurement of electrolytes in whole blood. Step 2. Hemolysis. To measure potassium, the blood is hemolyzed and diluted with water, as described above. For the measurement of calcium and magnesium, the blood is hemolyzed with ultrasound. Ultrasonic hemolyzer is a constructive part of blood analyzers, for measuring of hemoglobin. Step 3. Measurement of electrolytes in hemolysate. Step 4. Simple calculation relating to hematocrit and calculating out of plasma concentration. The ability to capture the complete intracellular status of electrolytes means a new dimension in knowing the organism's electrolyte status. And this has an enormous scientific and clinical relevance. Here is a short SWOT analysis. Strengths. The main advantage and strength is the absolute market vacuum. Weaknesses. The greatest weakness of the project is the absolute unknownness of the parameter in the medical and scientific world. The large clinical studies are missing. The skepticism is inevitable. Opportunities. The great opportunities lie in the new generation of analyzers for measuring intracellular electrolytes. This will lead to market expansion. Threats. It will probably need to fund some extensive studies. With the acquisition of clinically relevant data, marketing will also become easier. But in principle, the economic risk is quite manageable. A conceivable scenario for the introduction of the method into practice. 1. Disposable device for blood sample preparation. The production is simple and possible from many manufacturers. 2. The software upgrade for blood analyzers for the calculation of parameters. 3. The complete automation of the method. It is obvious that this automation will not cause any problems for the medical industry. We provide the technical documentation for the depicted device for each manufacturer.